All right, we will go ahead and get started. Good afternoon. Welcome to the HFMA Colorado Chapter Summer Webinar Series. We want to take a moment first to recognize our annual business partners. They not only provide us financial support to our chapter, but they also share their knowledge and their expertise through speakers and presentations for us. Their support allows us to operate our chapter and bring our members quality education and resources. We hope that you will take a look at them first when your organization needs services or support. For today's webinar, we will be using the Q&A box located at the bottom right of your screen. We will be monitoring the Q&A panel during the presentation, and we'll answer questions during the Q&A at the end of the session. A link to download the presentation is provided in the chat, and it will also be sent via email at the conclusion of our webinar. Today's webinar, Stop Revenue Lost Dead, Recover Millions You Already Earned, is being provided by one of our silver sponsors, AccuReg. Our presenter today is Jace Durard, Chief Revenue Officer. Before joining AccuReg as Chief Revenue Officer, Jace held executive roles with Zealous Payments and Passport Health and worked in sales and operations management for AIM Healthcare Services, amassing 25 years of revenue cycle solutions experience and a philosophy of delivering outcomes rather than products. Jace is a leader by example who models active listening, constant learning, thoughtful questions, and a readiness to step forward first. Mr. Durard graduated from the University of Tennessee, Knoxville with a BA in marketing. Join me in welcoming Jace Durard.
All right, that was very kind. I know who wrote that, and I have to give her a royalty every time someone reads that. So this is me, just in case anybody wanted to know what I look like. Not that you can't see me. I guess you can see that I've grown a beard. That's what COVID-19 does. It makes you a little bit lazy when it comes to shaving. I'll back up a minute here. We're gonna, as Jessica mentioned, we're going to talk about, my slide's working a little bit better. Stopping revenue lost dead. Recovering millions that you've already earned. I hope this is an interesting topic. It's one of my favorite discussions that we've done over the last several years. And I think that it is very relevant given our climate today. And we'll talk about why that is here in just a moment. So in our agenda today, we're going to go over things like revenue challenges that are facing hospitals today. What are those? How can you, do you see the train coming down the tracks? Are these the same challenges that probably most of you deal with every day, but they just never seem to stop? We'll talk about the traditional approach to bottom line growth. And note that I'm saying bottom line growth. I'm not going to talk today about net patient revenue. And that's something that we hear all the time. But at the end of the day, your organization, especially your CFO, is interested in bottom line growth. And a lot of you in the roles that you're in are really focused on a subset of that, which is net patient revenue or AR or something like that. But all of those numbers roll into bottom line growth. So that's where we're really going to focus today. We're going to talk about the role of predictive analytics and how they can reveal some areas of opportunity. We'll talk about objectives and tactics that can also reduce your cost, increase your cash. And then finally, I want you to walk away with something. And since I can't give a giveaway today, I'm going to give you some strategies that you can use to implement that will hopefully put millions of dollars back into your revenue cycle. So that's the agenda. What do I want you to learn today? We always want to learn things when we go through this stuff. So learning objectives, the first one is going to be, I want you to learn how to create a good, solid strategy to take advantage of revenue opportunities that you've never thought of before. Or maybe you just didn't know how to get them. Maybe you thought you were doing everything you could do, but you just don't know what you don't know. So I want to help give you a way to develop a strategy to go after those dollars. We hear a lot about AI. A part of AI is predictive analytics. So I want to talk about how you can actually use what's really become an overused buzzword of AI and then predictive analytics to help recover maximum dollars. And that's what we're talking about, is finding what would otherwise be potentially lost dollars. And then finally, we're going to talk about how to, well, not finally, there's one more, how to prevent some very costly denials and adjustment errors from ever happening, and just prevent the rework that you have to do. And now, finally, what we talk about often is how we can eliminate upfront patient cash by capitalizing on missed, increase upfront patient cash by capitalizing on missed opportunities. So let's start in with agenda topic number 1, revenue challenges that we all face. So what are some common challenges that we face every single day in the hospitals all around the country and in your own state of Colorado? Well, first of all, we face some pretty significant loss to adjustments, bad debt write-off, denials, etc. It's a big percentage of hospital dollars that get lost to that. Now hospitals are losing out on even potential cash that they don't even know about. And maybe that's on balance billing. We've got a lot of legislation coming out. And even worse, if that wasn't enough, patient revenue is down just due to the pandemic. So if we didn't have enough to deal with, now we've got elective surgeries that have been down. Most of you missed out on 3+ months of revenue because that was stopped. And now, we're trying to claw back into some semblance of normalcy, whatever that may look like. So I can tell you as an example, one of our clients actually furloughed 1,500 employees due to COVID-19, and they're still doing that. They're on this rotation of furloughing these employees. So they're still reeling from that challenge, and we still hear about it all the time, all over the country. So even though we have these risks and these things we deal with, we still need to realize that there are certainly opportunities for bottom line growth. But normally that happens in one of a handful of ways, either by patients coming in the door, just new patients coming in the door. That's just customers, right? It's new patients, and yeah, they are customers. Or a lot of hospitals will make very smart investments. That's not even, they just have a fund and they'll invest in technologies in healthcare or around healthcare, but that does keep a lot of large hospitals, especially the for-profits, it keeps them moving. And that's something that's not really talked about ever, but it's there. And I'm not sure whether your hospital may do it or not. And the third way is just reducing expenses. There's a significant revenue value that's already lost to operational costs, administration costs, denials, etc. And that's just your cost of doing business. So you either got new business, you got smart investments, or you got expense reduction, okay? That's just opportunities, traditional opportunities for bottom line growth. And when I say new patients and new customers, I'm talking about going through the existing process that we have today. Don't change a thing. But you got to throw that one out a little bit, right? Because we've been through all of the things we've been through this year. So in the absence of new dollars coming in due to COVID-19, we have to think differently. And we have to ensure that when someone does come in, we're capturing every bit of that revenue. We're getting all the juice out of that lemon, as they would say, right? So we need to look at a fourth, and this is where we're going to talk about today, and that's maximizing the revenue opportunities that already exist. So while net new revenue is really important, finding that revenue that's already hidden is really easier than standing outside and trying to, find patients that can't come in for one reason or another. So let's go and drill in and look at some other opportunities to start maximizing the revenue that already exists. Okay, so let's talk about three. One is denials and rework. We can focus in on our denials, we can focus in on our rework, and that's going to start maximizing our revenue. 2, we can focus on patient responsibility, and 3, we can talk about adjustments. That's really those 3 ways that we always think of. And for 25 years, I've gone to these HFMA presentations, and they all talk about one of these, not all, but very often they talk about one of these 3 things. So how are you going to react and capitalize on these things today in the light of a very different world? So here's where I'm going to start talking a little bit about using some different technologies and using what's called predictive analytics. Okay, so predictive analytics basically is instead of simply presenting information about past events to the user, predictive analytics estimate the likelihood of a future outcome based on patterns. And so it will allow you, whether you're a clinician, administrative, in finance, to receive some sort of alert or some sort of notification that something is about to happen. So it's basically saying behind the scenes, based on this, based on X, Y is about to happen. Similar to, say, Amazon. If you put something in your cart on Amazon, you'll have a pop-up before you buy, and it says other purchasers of this, other purchasers, people who bought this also bought this. That's predictive analytics, and that's modeling, and that's what we're talking about here. So the challenge is to find ways to adopt predictive analytics and leverage that. So why is that important? Well, because you not only do you want to be able to identify patterns and errors, but you need to be able to prevent them. So it's kind of the reverse of the Amazon. Amazon is saying, okay, you're buying this, other people like you bought this. What we would be able to do in healthcare is use these predictive analytics in a clinical setting to say, based on this person's pattern of medical care, they're likely to have this problem. Or in our world, on the rev cycle, based on this pattern of denials, this is likely to happen. So let's stop before this claim has a heart attack. So instead of taking information about past events and just giving them to a user, predictive analytics are estimating the likelihood of that outcome based on patterns. So it's also called modeling or modeling behavior. I'll use those phrases a lot throughout the presentation. And so really payer and provider organizations both can use this type of data, the analytics, in very different tools to work your financial, administrative, data security, and all kinds of areas to really see very significant gains in not only efficiency, but also customer satisfaction. So it's really it's more than just looking at the data, it's analyzing the data, looking for patterns and trends so that you can develop and implement a strategy that addresses the areas of opportunity. That's what we're looking at. Let's talk about using a technology. Let's look at an area, a set of data. I mean, data is just one of the most powerful things that we have. I have had a saying, I've always said that he who has the data wins, and you all have the data, but you've got to use some different technology to drill into it, identify patterns. If it's repeatable, it's predictable, it's preventable. And that is where AI and predictive analytics will come into play. So where do these opportunities exist in the revenue cycle? Well, first of all, about a third, what you'll see here is about 46%, about 46% of errors and denials occur on the back end. So when you look at that chart, that's the first thing that jumps out at you. Well, almost half occur on the back end. So natively, you're going to invest most of your time and money on the back end, right? But what you also see is that the front end represents about a third, about 37%. of all denials come from the front end. And that's the place that it's easiest to make a big impact. Remember what we're talking about here. We're not talking about denial rates only. We're not talking about net patient revenue. We're talking about bottom line. It's not really that big of a lift to prevent these things from happening on the front end if you have the right tools in place. So if most hospitals in the country focus your efforts on fixing things on the back end where 46% of the denials take place, I don't necessarily blame you for doing that. But why would you want to look at the 37% up front, which is the smaller number? Well, this is why. Because the dollar value shrinks. It shrinks. If you look at this chart, you see what this is representing are different stages in the revenue cycle. And we're starting with a payer and patient dollar value of just $1. And we've done studies that show that the dollar value obviously is at its highest point before the patient walks in the door. You haven't done anything to them. You haven't even greeted them at the door. They haven't even paid for breathing your air conditioning. Nothing has happened. But as they go through the physician order, as you go through patient scheduling and registration and insurance verification, if certain things go wrong, that is your highest likelihood of losing value on the dollar because of the mistake that will carry all the way through to the end. And what we know is that the dollar value shrinks the greatest at the front end and is at the lowest at the back end. In fact, if you're trying to collect a dollar that's gone through the normal process and you haven't done any upfront prevention on that, nothing has changed. Most often, the dollar that you're paying a collection agency 10, 20% to collect is only worth 15 to 20 cents on the dollar. 15 to 20 cents on the dollar. If you were getting that money up front, it's worth 85 cents on the dollar. At its lowest point, maybe if everything has gone wrong and you get to insurance verification, you catch all of it, you're at 59 cents on the dollar. It's way better than 15. So let's take a look a little bit closer at some opportunities for denials. So the first thing we have to agree on in this thesis, in this discussion, is that all denials are not equal. You know, just because you decrease your denial rate doesn't mean you have more money in the bank. You're just kind of managing to a statistic. You're not making an impact on the bottom line. Okay? The stats that you're held accountable to in rev cycle is not the end game, but we're starting to peel back the layer a little bit of the onion. Okay? So those of you who have done this for a long time, you know that simply decreasing doesn't lead to cash in the bank. And in fact, some denials represent lost dollars from payers, but others represent lost dollars from patients. Now that may be something that we haven't really dug into a lot. Some denials are from payers. And when you are addressing that denial, who are you trying to get to pay you? The payer. But sometimes they truly don't owe you. It's the patients that owe you. And those oftentimes go on to be written off because we don't figure that out. So how do we interpret from our denial reports so that we can understand what denials represent lost dollars from payers versus what represent money from patients? So let's interpret these things. Roughly 25 codes will appear most often on claims. About a third of lost reimbursement comes from payers, about a third. But then actually, you may not be paying attention to the remaining 2/3 that lack coverage. So that represents missed opportunity. This may also be, let's think about this. When you are appealing a denial, what does that cost? I've seen statistics from $90 to $130 that it costs to appeal a denial, appeal a claim. So if that claim is not going to get paid because it actually represents a lost opportunity for patient cash collections, not only you're losing the money on the claim, you're losing the money on the work that you are doing to resubmit the claim that never should have been filed in the first place. It never, ever should have been filed. So we're going to pound away on this. While every denial is associated with a dollar amount, not all of them represent dollar from payers. The key is to understanding where the money lies and understanding of what a denial description means. So we've got to understand that first. So I'm going to go take us back to day one of revenue cycle. And I'm just going to talk about basic definitions because this is the blocking and tackling of what we are discussing today. A denial, a claim or line item or service line item that results in no payment, including rejected claims. A soft denial is a temporary or interim denial, but it does have the potential to be paid if the provider takes effective follow-up actions. So you can get paid on the soft denial. The hard denial results in lost or written off revenue, which are often tracked in patient accounting information system using transaction write-off codes. And then we have preventable denials, which is a hard denial resulting from action or inaction on the part of the provider of services, which often involve elective services that could have been delayed or deferred. So you understand what the denial report is saying, but what does this tell us about how to prevent denials in the future? Okay, so here's where we find the 835 and 837 pay remit data very, very useful. This is going to be your source. Okay, this is where you're going to go to really drill in, and what you're mining for here is gold. You're mining for dollars, patterns, trends that you can affect next month, tomorrow, next week. When we analyze this AITS data, that's what we call it, it's AITS data, you can begin to size up the opportunities in your hospital or health system. So let's look at an example here. So if you look at this example, which comes from a real hospital, you've got front-end denials totaling $117 million. $117 million. 97% of these front-end denials are preventable, while only 3% were not. And again, we've got $116 million in preventable denials. Okay. So where do these front-end denials come from? Well, they come from scheduling. They come from coding. They may come from registration. So they come from all over areas. It's not necessarily one spot. So you really have to drill in and see and start finding, peeling back yet another layer and yet another layer. So let's look at where we can find that opportunity. When we see a high denial amount associated with the front end through eligibility, authorization, MEDNEC, and data quality, we want to drill into that. We want to drill into that. So in this example, we're looking at $68 million, 58% of preventable denials were due to eligibility. Let that sink in for a minute. 68%, $68 million gross charges, to be fair, $68 million of denials are due to eligibility. I wonder if anyone on this call does not verify eligibility on every single patient that walks in the door. I bet every one of you do. So does this hospital. And they have $68 million of preventable eligibility denials. 34, I'll call it 35 million in authorizations, 5 million and 7 million in data quality respectively. That's a lot of dollars that's already there. And using AI, using predictive analytics, this would still happen. This would continue to happen unless you use the data to stop it. So data can turn into your weapon as well, your tool for finding money. So now let's look at the preventable denial. So I've categorized them there as preventable and unpreventable. So we've discussed that category of preventable plus some subcategories. And now you start to see what we have been discussing. I'm saying a lot of these things over and over, but that's for effect because you start to drill in and see these things. So can we do something to prevent these denials? We're looking at the opportunity differently than we have yesterday. And now you can start to build strategies around these preventable denials. And once you drill into them, however, the fastest lift to your bottom line is going to occur earlier in the bottom line or earlier in the system. So when we see what's on your screen now, we're looking at things like your preventable denials being some contractual allowance, patient responsibility. That's $19 million and reclassify as patient responsibility. We've got 7 million in just errors. We've got 8 million as just soft preventable denials. These are lots and lots of dollars that go unaddressed, but they can be addressed because there's patterns inside them. So now we're looking just at your front end denial rate again for this hospital. What I want you to notice is just when we look at the unpaids alone. So in this example, we've got authorizations at 4 million. We have paids at 1.3 million, unpaids at 2.4 million. 2.4 million of unpaid authorization. Look down at eligibility. There's 1.8 million of paid. There's 2 million of unpaid. And just look at what's included in that unpaid category. Care covered by other payer. That's an easy one, but there's $600,000 there. Expenses prior to coverage, expenses after coverage. Patient not our insured. That's 8% of the dollars there. Patient not our insured. How does that make its way to being a claim? Because the eligibility response would tell you that. Eligibility requirements not met. Perhaps that's more associated with benefits than eligibility. Claim not covered by payer. Again, maybe that's benefits, not eligibility. Oh, wait, there's max benefit reached. Hospice patient. These things are examples that are told up front. You have the information there, but for one reason or another, it's not dealt with. It's not dealt with. So there is an opportunity here. Talk about eligibility as one of the largest, it's one of the largest missed opportunities for patient collections because the claims should have never been filed. Never been filed. So by the time you add in reducing costs because the claims shouldn't have been filed, this is a 14-point swing, as we would say in football, right? This is, you're spending, let's call it $100 per claim to do the rework. When you look at just the 209 or the $81 claims for expenses prior to coverage times 100, that alone is a good dollar amount. But then when you add the value and say, wow, not only should I not have ever had to rework this, we never should have filed it in the first place. I should have asked the patient for this dollar. So you're reducing your cost and raising your point of service cash collections. That's a 14-point swing. What would it look like if this were to happen? It would look like what I just showed you with my hands, if you're seeing me on the screen. They never should have been filed. So now we've talked about the front end. Let's take a look a little bit further back at even some of the middle tier denials. So these are denials that have been classified as middle or later stage of the patient visit, but we still see non-covered charge in there. We still see it. If this facility had had a strategy to identify and really check benefit validation earlier on and react to it appropriately, even this middle tier denial could have been prevented. Even the middle tier denial could have been prevented. Let's look at patient responsibility. So up to this point, we've been talking about non-covered services. However, even in that same AITS data that you have, if you analyze it correctly, you can see patient responsibility by payer for covered services. Whereas the patient responsibility we're seeing in the eligible denials show patient responsibility for non-covered services. Okay, so you can actually look at it and say, look, this is something for covered services, and there's patient responsibility that should have been collected. And this particular facility missed all of this. All of this. Now, seeing the data, they start to build a strategy. So you should be able to see what you could be collecting from your patients for all these covered services. The payer pays their portion, the patient should be paying their portion, but are you asking for it? Do you have the right tools up front to even capture these charges and some sort of estimate that you might do? This facility, I think we can look and say they were struggling with that. They have a lot of opportunity to do better. Okay, a lot of opportunity. What if we look at another location? What if we look at adjustments instead of just patient dollars? When we look at these adjustments, we see that most of them are coming from authorizations, and they tend to be write-offs. So how are we addressing that? Well, I think we need to drill a little bit further into the data to see how we're going to prevent these authorizations adjustments. When we look at the next screen, these physicians make up the authorization denials that we just spoke of, okay? We see a couple that really jump out. The first and second one make up 26% of all authorization denials. So in this case, you have to start using some analytics to show which of the physicians have the poorest record of submitting correct authorization data. And once you identify that, then you can start to create a strategy around corrective action for these particular providers. You model the pattern, the behavior of the physicians, okay? And what we want you to know is even if you use the right technology, you can pattern where these issues occur and you can maximize revenue for the opportunities. If you were at your facility and you says, and a patient came across the desk and it was a referral from Dr. Jones, who was your biggest offender, you need to know right up front, this is one of Dr. Jones's patients, we need to double check because they're just not good at getting things authorized before they send them over. Here's an example of two hospitals, the same amount of gross charges, but two very, very different strategies for getting paid. And maybe this will illustrate what we're talking about here. When we look at these, we see the same pre-existing conditions, the same billed charges, but the action was different. Hospital A billed the payer for everything. Okay, billed them for everything. Their denial rate was 12%. Hospital B referred the first one to financial counseling. The second one, they billed to payer. The third one and fourth one, they put on a payment plan. And because the fifth one had no authorization, because maybe they captured who the physician was and double checked it, they rescheduled that patient. Their denial rate was 2%. 2%. So what's the lesson? All of Hospital B's all of the actions at Hospital B were patient payments. Not a penny came from insurance. Not a penny. Everyone is focused on the denial rate, but what you need to be focused on is where the money is coming from. And you've got to use technology to tell your staff how to deal with what patients in what way. Do we send them to financial clearance, or do we set them up on a payment plan? Or do we reschedule them? all of the dollars from hospital B were patient pay. All of the dollars from patient A, what, 88% of them were denied. So who made more? Who made more? Not a penny more came from insurance. So let's start developing a strategy. And what would that look like? Well, okay, start with denials. So what do we know is going to result in a denial, and do you track that? Okay. What errors do we know are going to lead to denials? And who is going to make mistakes? For example, do you know what doctors are always going outside the bounds of an authorization and therefore causing a denial? So you see, I'm starting to ask these questions about different areas of the revenue cycle. I'm not asking questions that drill into how quickly you're checking eligibility or when you're doing that, although it's important, but a lot of you do that today. Remember, we just saw an example of a hospital that checks eligibility every single day and has $68 million of eligibility denials and some huge astronomical number of authorization denials. So now I'm saying, do you know what doctors always go outside the bounds? And can you do something to capture that information early on? So I'm asking different questions that allow you to make decisions. Where in the revenue cycle are most errors occurring? And are there departmental or technology changes you can make to address those? What are some tactics that you're going to use to achieve these objectives that you're going to set out? The objective of our strategy, what is it? Well, it's to reduce our cost and increase our cash. Reduce costs and increase our cash. We're going to increase our cash by maximizing the value of the cash you collect. You've got to eliminate operational costs associated with correcting on the back end. And we need you to start thinking about what processes you need to put in place to accomplish this. How are we going to eliminate the unnecessary claims? How are we going to eliminate appeals? How are we going to eliminate operational costs? And how are we going to manage physicians the right way? There's only so many ways you can be profitable. I mean, you have to have low expenses and high cash flow. If your facility has the cash flow, which they mostly do, you've got to keep expenses down. And right now the cash flow has dropped. So you've really got to make sure that our operational cost is low. And that doesn't mean furloughs for everybody. It doesn't mean that. For some, yes, but not for everyone. This is a viable option for you. How are you going to get there? Let's talk about increasing our cash. Identify patient collections. Develop some collection points for patients prior to service even. So I always say the best time to collect money from the patient is any chance you get. You have to give the patient multiple opportunities to pay and multiple vehicles to pay. Okay, so first question, are you asking for money every chance you get? Second question, are you giving them multiple options to pay? Credit card, cash, check, etc., payment plans, bank draft. The third question is, are there other opportunities and vehicles that you have not implemented? Can you create more opportunities for them to pay, more opportunities for you to ask, and more vehicles through which they can pay? And here's a good question. Are you meeting the patient where they are when you're asking them for money? And where they are most of the time is right here. This is my phone. They're on their phone most of the time. Do you have a way for them to pay via mobile app? And finally, we've got to develop better authorization screening processes. And that involves patterning the behavior of your system, your providers. Okay? So now let's take a look into the different opportunities that are in front of us. And the process that we go through in developing this strategy starts with capturing the data. You've got to capture the data. You have it, the AIDS data. And then you've got to normalize it and then you've got to analyze it. Okay, the analysis is what I've been walking you through thus far. Then we have to develop a strategy, which is what we've been talking about. And then finally, we get to the next stage, which is execute. So how do we execute? And for those that want to jot this one down, this is a really good slide. I know you might have the information. But capture the data, standardize it, analyze it. Capture, standardize, analyze. Then develop your strategy and go to work. Let's talk about executing the strategy at this point. Okay. The scary part of it is to execute your strategy, you may just have to change the way you do business. Okay. One way that we help some customers is by developing a strategy like this is to perform a deeper level of benefit validation. Okay. And then you've got to take some initiative on pre-reg collections. Okay. There's now there's even an opportunity of pre-reg. Okay, so pre-reg alone is not really good enough anymore now that we've got COVID-19. Now you're shifting into more of a touchless process in patient registration. So we're going really 2 steps up, into pre-reg, which is, again, another opportunity and another vehicle, okay? You create accountability in the patient access. You monitor and react to exceptions, okay? There's new processes, there's new workflows that your staff has got to start following, and that will change their behavior. It'll become muscle memory. You change it a little bit at a time, but their muscle memory starts to change. You start to get different results, okay? With a pre-reg initiative, you start to create workflows, and you start to know where to move patients through the process. And as I said a moment ago, this creates opportunities in vehicles. So one of the things that's very helpful is some type of alert system that says, hey, stop what you're doing, denial walk-in, denial walk-in. This patient's not gonna, this payer's not gonna pay, or you're not gonna get paid. So here's an example of an alert, okay? And in this example, the patient access staff, it said there's a lack of coverage, which means what? They need to collect from the patient at scheduling. At scheduling. I said earlier, if it's repeatable, it's predictable, it's preventable. When you drill into those 8s and you start peeling back the layers of the onion, okay, here's a category of front end, middle, back. Here's the category of preventable, unpreventable. Here's a category of paid, pending, unpaid. Here's a category of eligibility, authorization, med-nec, data quality. Here's the pattern of soft, hard, all the different things. And then you start getting down to the payer and you start seeing these patterns of codes. And you start learning, hey, I should have seen this because this one matches this one, matches this one, matches this one. If A equals B, then C. So when all this runs in real time, you should be able to create a rule system or have a rules engine that'll find these patterns and communicate to you, to your staff, in a workflow that's exception-based, that's enforceable, that provides scripting on how to correct it. Your strategy goes beyond just eligibility. But when you have this in place, you start to, again, create a pattern of success and a pattern of muscle memory, right? You even go so far as to reschedule a patient when the software will tell you. And that goes into physician adherence, right? Okay. In this example, authorization required and obtained. So good. What if it hadn't been, right? So you can either use manpower or technology to intervene when the root cause, when you start identifying the root cause of an error. So what are the conditions across different scenarios? You've got to build a rule or algorithm to prevent it. You've got to build into a tool that's applied every single time. that you register or schedule a patient, every single time. Okay. And then can you begin to write rules that automate the correction of future errors? Yes, you can do that. Yes, you can identify these similarities. So for example, where in the revenue cycle are most errors occurring? And are there even departmental or technological changes you should make? Even further, what about the implementation of the strategy? What about staff training? Let's talk about staff for a minute. The job of patient access really is to compile and correct. Your first line of defense is patient access. That's their job. Put simply, you compile and correct. You compile information from the patient, and then they correct the data that's wrong. But if they're going to do that effectively, you've got to make sure they have the tools to do it effectively and do it correctly. And what we're talking about today is that in order to give them the tools that do this effectively, you might need to find tools that are drilling further into the data, or you need to start drilling into the data yourself. The tools that you have may have been great in January or February, but now we're on a revenue shortage, right? Our bottom line is being impacted negatively. So now we've got to look and see where else can we find money? Well, it's in-house. It's in-house. I'm telling you, it's in-house. But are you using the right technology to drill in enough to the data that you have to find the dollars that you have? Okay, if you don't have the staff today to facilitate even training, then you have to have the training automated even. So if you're making all these changes, who's going to train your staff? See if you can have that built in, and then start to pattern everybody's behavior, not just physicians, everybody's behavior. Okay, so start, including patient access, learn where they need to be trained. So alerts. So if we have the machine identifying exceptions and they're eliminating the need to check all accounts through automation, that's going to increase their productivity, right? Workflow. If you can identify actionable issues and you can save staff the time of manual processes for checking all the accounts, you're increasing their efficiency and making a better workflow through the machine. Reporting should give you visibility to the registrar, to management, and when errors occur, they should be reported and resolved. How many errors happened, how many were fixed, and this provides visibility in the staff, performance, and so then allows things to be enforced, which leads, of course, to accountability. If you use that reporting data, you can make compliance to the new and improved process enforceable, and you can ensure that your staff is doing the right job. And it may be new. They may be doing new things. Finally, and it's certainly last but not least, it has to be, you have to benchmark things. You're not just telling the staff what's wrong, but you're telling them how to fix it specifically, and then you're holding them accountable to fix it and prevent the same error from continuing in the future. Okay, that's the point of all of this. Where are the dollars that you're missing? How are you missing them? Are you missing the same things all the time? Here's a strategy in front of you. Get some exception-based alerts. Provide an automated workflow that tells your staff what to do. They're going to do a new process. Enable some reporting that drives some accountability so you know they're learning and doing their jobs well, and set benchmarks. The benchmarks won't necessarily be denial data or your denial rate, but it may ultimately be your bottom line. Man, if your bottom line goes up, even though your revenue has gone down, that's a win. That's a win, especially right now. But it's going to take people, processes, and systems. People, processes, and systems. If you go and implement a change halfway, you get half the ROI. The more you do, the more you get. If you focus on your people, you're going to get this much lift. If you focus on just the process, you're going to get maybe a little bit more. If you put some awesome system in place, you know what? You might get a great lift. But if you go a step further and you build your strategy, oops, I went too far. That's me. Sorry, guys. And you build your strategy around employing all three, making sure your people are doing the right things and you've got the right people in the right place. You're improving your process by putting in new systems. All three of those give you the maximum ROI. The ROI of each one of them is stacked on the other. Stacked on the other. I hope you've gotten through this, that the more comprehensive your strategy, the bigger your return. I hope that you've gotten through this a way to, and some new ideas as to where you can look and find revenue, find opportunity that you may not have looked under, just a rock that you haven't uncovered yet. And then maybe giving you some tactics of how you can really find out what's there and where you need to spend your time and effort. With that, I will open the floor for questions.
Thanks, Jace. It looks like we do have one submitted question so far. Before we get to that, I do just want to remind everybody down at the bottom right hand of your screen is that Q&A box. Feel free to pop your question in there if you have any. You can also use the raise a hand feature, and I'll watch that. And if anyone wants to do that, we can get your questions that way. The question I see is, we want to start digging into our denials data, but how do we obtain the payer remits?
Yeah, great question. So back up a minute here. So payer remit data, it comes from the payers, but there's just different methods on how you can obtain them. A lot of hospitals, IT will run queries and they'll pull that data. You can mine payer remits themselves. Some will get data remits from your clearinghouse. Some will even go directly from different payers who can put that data out on a VPN, and that's made available to your hospital. So I would talk with your hospital's business office director, rev cycle manager. That's probably most of you on the phone. You'll know who to ask. There can be costs involved in obtaining historical remit data, but it's also pretty valuable data if you don't have it, okay? From there, you'll want to start doing some standardization and some normalization. Remember, that's kind of that circle that we went through of capturing the data, standardizing it, and analyzing it, okay?
Thank you, Jace. I am not seeing any other questions right now. I just want to thank you so much for providing the excellent information. We appreciate you sharing your time and your expertise with all of us. Oh, hey, we've got one that popped in. We want to start analyzing our denials. Do you know of a resource available that has created a map to CARC and RARC codes into the different categories? For example, eligibility, med necessity.
Yeah, the CARC codes. I can probably help you with that. If you want to email me offline afterwards, I might have something accessible that can send to you. So my email's up on the board there. So if you want to just copy that down and email me, I can probably send that to you.
Awesome. Yeah, and just as a reminder to everyone here, the presentation was emailed out. It's also available in the chat box. There's a link to download it, and all of Jace's contact information is in there as well. And it sounds like he'd be happy to answer any other questions that may have come up for you all.
Yes.
Before we go, I would just love to point out that we have a member virtual happy hour coming up on September 17th. You can register for it on our website, which is www.hfma-co.org. These are a lot of fun. They give us a great chance to just kind of mix and mingle with our other chapter members. It's just a light, fun event, and we'd love to see any of you there. With that, that does conclude our webinar for today. So thank you all so much for sharing your lunch hour with us. Thank you again to Jace from AccuReg. We hope to see you guys all again really soon at an event coming up.
Thank you. Bye-bye.
Thank you.